Good morning, good afternoon, good evening, everyone. Section 3, here we are, week 2 wrap up, talking about hip OA, buttock pain, iliotibial band pain, all things hip related. I just want to start off by saying that, another good week. A lot of people got in and did some good discussions. I want to encourage everybody to not leave your threads open, but always make sure that you close your threads and always make sure you try to get into those discussions. You don't necessarily have to get into them on Thursday night if you got something going on. I totally get that, but don't wait till Saturday morning, late Saturday morning, to finish your threads. You can get a better discussion going, and you can learn more from this if you can dig in and respond to people's posts and get questions answered and get questions started. So I want to encourage them. A lot of people, there are some really good groups who got a lot of dialogue in, and I really appreciate that. And there's others who will get more in as we go along. I'm sure every week is going to vary for different groups. So in regards to the weekly review, the lower extremity nerve entrapment video by Dr. Anderson was, it's a great opportunity to clean up our peripheral nerves for the lower extremity nerve screens. I think we oftentimes forget about that, and I really find that this is a very, very valuable tool. And a lot of the stuff that we deal with has a nerve component to it. And, as we get into this further, I'm going to speak to that. I find that to be very common with the quote-unquote diagnosis of plantar fasciitis. Medial knee pain oftentimes has a component of a neural tension to it. Obviously, groin pain certainly does, but and anterior thigh pain, obviously femoral nerve issues. But I just think that's a great review. Manual therapy of hip disorders and the common bony hip disorders that Whitman talked about. The Minkin stuff that was put together digs into the FAI, the labral issues, both surgical management as well as rehabilitation. I think that stuff's important. I think we got to know. The hip disorders, they were a great opportunity to discuss the differential diagnosis of all things hip, from hip fractures with greater risk for DVTs to the FAI and the labral pathology. We need to be aware of these things. We need to be educated so that we can treat our patients accordingly, so that we can properly refer out from a direct access standpoint. Some of the literature behind conservative management of these diagnoses is okay. It's not great, but I don't think the surgical interventions are all that great, to be honest. I'm not impressed with the research. It's a lot of cohort studies. They're not really ever demonstrating comparable to conservative management. I don't think they really want to do that, to be quite honest. I don't. But FAI and labral tears, gosh, I've had a couple of labral tears in the hip for older patients, in their 50s and 60s. And I just ask, why are we doing this? Is this really the pain generator? And these people are coming to me, obviously, after surgery, so I don't even get to broach the topic. But I think that for the younger athlete, it's a perfectly appropriate thing in a lot of cases. But for the older people, it's just part of the wear and tear. So be mindful of that as well. The Handel article, I think that's just a great example of how to follow an evidence-based protocol. Certainly there were some criticisms in regards to the quality of the research. I wouldn't look at this article as a research paper. I would look at it as simply a way to get an evidence-based approach, manual therapy techniques out there into the public viewing so that discussions can take place. It was really more about getting the techniques out there and seeing what these techniques were and getting exposure to them to other people. I know people talked about or nobody actually talked about this, but compliance. Nobody really mentioned this in the Handel article. The compliance wasn't very great. How important does compliance need to be? I think that would be a worthwhile discussion that we got into after 6-8 months. Do people with hip OA or have hip stiffness, are they destined for a life of exercise? Do they need to do? I always tell my patients, you're not supposed to do these exercises in perpetuity. Do hip OA patients need to? They need to do something. Do they need to be active in some way to keep that mobility and strength? Do they need to continue to do these specific exercises? Nobody got into that discussion, but I think that's a worthwhile one to talk about. The Vance Duvin article, the trochanteric bursitis, 68% of these athletes had tendinopathy. I thought that was a very interesting statistic that when they MRI'd these people, 68% of them, they found tendinopathy in the gluteus medius, and I was like, that's classic. There was a discussion, I got into a couple of threads about, some of these diagnoses, piriformis syndrome, hip bursitis. Do we really know what this is? Is this really what we're testing? The special tests for these aren't great, and we kind of just pass off these terms kind of arbitrarily, and yet we know that if they have stiffness in their hip, if they have stiffness in their low back, if they don't have good stability in their gluteus maximus, medius, and minimus, so they don't have good strength there, that these people have problems, and yet we label these diagnoses that may or may not be correct. So think on that too. The Van der Werp article, poor studies, they talked about in the poor methodology related to iliotibial band. They talk about Nobel's compression being the gold standard. They don't really specify any specificity or sensitivity for Nobel's. I question it being a gold standard. That test is a nice clinical tool, but I wouldn't bet my lunch on it, as the saying goes. And they did say that in that Van der Werp article, they said, and I quote, "These runners tended to train by running long distances at low speed, wearing New Balance shoes, and run on tar dirt roads." But yeah, like New Balance has a skin in the game here. They want their name being dragged through the mud. I would be willing to bet if you put an Adidas shoe or a Nike shoe. I'm a bigger fan of the Adidas gel personally. They've gotten me through 2 marathons. I don't know if New Balance really is all that important. It's interesting they found that needed to be noted. Outstanding posts. So some things that I thought I caught my eye and I wanted to mention. And first, I want to apologize to you guys. I don't think Jason even put out a week update, but I just forget on Thursday nights. After I get done reading through so much, I forget to send Jason some shout outs. So I'm going to do a better job, I promise, from weeks 3 moving forward. But you guys there's been some really good stuff. So I really liked Megan and Will, and they had a great dialogue on hip pain and the relationship with physicians. Megan posted a rehab protocol that they use. I thought that was really good. And this relationship with physicians about kind of this prehab, if you will, going to see somebody before surgery. If you make them feel better, do you dissuade them from having surgery? How you handle that whole relationship without upsetting that balance with your physician. Obviously, it's always the patient's decision. But I've had a couple of patients who it's interesting when you get to work with them, how they start to move better and they start to think, maybe I don't need this surgery. And obviously it's their decision, and you just say, well, it is how you feel. The surgeon's not really going anywhere, and he'll always take you. If you feel like you don't need it, that's certainly a decision you can make. That's kind of how I leave it. Josh does a great job of questioning some of the research related to buttock pain, and then the diagnoses. I've already spoken about that. Josh, I thought he hit on some really good points in his thread, and it's very true. And then Pierre got into that as well. Matt brings up a good point about the evidence lacking manual therapy and THAs. I thought that was a really good point because we didn't get into that in this week, but I have an article that I want to just let everybody know. He said that there really isn't good evidence for total hip arthroplasties and manual therapy, but I will say that if you see enough of total hips, you're going to see these people come back. And I have not, I don't see a ton, but I certainly have seen enough, and I do manual therapy on them. If you check out this article in JOSPT in 2007 by Howard, and the title is Manual Therapy Intervention for a Patient with a Total Hip Arthroplasty Revision. Now, don't get me wrong, this is not, set in stone. This is a case study, an example of what can be done, but I will use long axis distraction. I will use lateral distraction. I will use posterior glides, all within kind of a neutral setting. I don't take them, I don't cross body. I don't take them to kind of end extreme external internal rotation flexion and then mobilize them, but I will mobilize these patients and they feel great. I've had really good success with that. But again, always caution is noted. Raul discussed the importance of using clinical algorithms for hip pain patients. He spoke about both the Altman criteria and the other clinical prediction rule to help kind of guide you in your process. And I can't stress that enough. For those people who find stiff hips and you're like, well, is this bursitis? Is this an FAI? The Altman criteria and the other clinical guideline for guiding hips for stiff hips is really a useful tool. And really, I didn't get this in school, but it's probably 8 years ago when I discovered these. It was extremely helpful. So I really appreciate Raul kind of speaking to that. Okay, coming up, week 3. We obviously have the CAP project. I've heard from all the groups. Everybody seems to have different articles. Continue to work together. Don't slow down. You've got until Saturday to get this thing rocked out, and then we'll start to discuss it next Saturday. But continue to work in your groups and continue to share information. Oh, also, don't forget when you post it on Saturday to attach the full text copy of your article. That helps us all kind of gear into what you're talking about. Week 3, we're going to talk about anterior hip pain. There's a number of lectures, less reading, FAI, labral issues, and groin pain, kind of pubic algia, if you will, of the athlete. I would like to say so everybody this time did individual posts, individual blocks of posts, and that's fine. But I would like to try this week if everybody could nest their posts into one thread. So what that means is, I'm going to ask that everybody who posts for Group Bravo or Group Alpha or Group Charlie or Delta, the first one to post, we'll say it's Josh. Josh posts first. And Josh is in Group Delta. I think Group Delta, then those people who will follow after Josh will reply to Josh and put their original post in a reply to him. So it's one continuous thread. Then you go ahead and engage in conversation by replying to each of the original posts. The reason I'm having you do that is because I think it makes it easier to get kind of a continuity of conversation. And if we do this for a couple of weeks and I get a lot of pushback or people like, I don't really like that. I feel like it's too hard to follow. The trains of thought are different and it just doesn't work for me. If I get enough of that, I certainly am willing to go back. But I realized this time we had a lot of posts that there was some overlap and we could have all had some similar conversations and shared some ideas in one continuous thread. And I think that I would like to try that anyways. So if I could all encourage you to do so. You guys are doing great. We're all getting engaged. We're all learning about each other's different styles. Everybody seems to be respectful to each other's thought processes and open to entertaining new ideas, feeling like don't feel threatened when people question what you're doing. Simply explain and further dialogue about, well, I do this because, there are going to be people who love leg lengths. There are going to be people who love to look at pelvic asymmetries, and we have to start to ask ourselves, where do we go with that? There are people who are obviously very much rooted in the McKenzie process, and everybody kind of has their perspective. And the idea of evidence-based medicine is that we take the best from everything and we try to guide ourselves so that our patient gets the best treatment approach. If you have any questions, feel free to contact me. Hopefully when people have, I've gotten back to them as soon as I possibly could. Other than that, enjoy your weekend. I'm going to watch some basketball.